Perfect. Well, thanks so much, Brittany. Can everybody hear me? Or Brittany, am I being heard okay as far as you can tell?
Yes, all good here.
Beautiful. Okay. Well, yeah, so I'll go ahead and get started. Like Brittany said, my name is Majdee. I'm a men's health specialist. So I specialize in things including treatment for erectile dysfunction. We'll get right into it, kind of right off the bat. Um, this little QR code, if you hover over the code with your phone, it'll get you to a little survey. This is a big part of how we actually will assess patients in terms of what their erectile function is like. And so this is something where if you're interested in taking the survey to see kind of how significant of erectile function or dysfunction you have, we use this pretty often to gauge the severity of folks' erectile dysfunction. So if you're curious what those questions end up looking like, by all means, use that QR code. So that's me. Those are my offices on the right. I'm at, for the most part, in St. Louis at the Walker Building. I also go to the Illinois side at a couple offices in Alton and Fairview Heights. But kind of moving forward, what I'll plan on doing is talking about erectile dysfunction in general, and then going in a little bit of detail about the treatment options of erectile dysfunction, going from things that are a bit less invasive, more conservative, all the way up to the more invasive procedures, and then we'll go from there. So right off the bat, erectile dysfunction, the biggest thing I always like to tell guys is it's not necessarily the inability to have an erection, period, but it's the inability to have an erection that's rigid enough to your satisfaction or patient's satisfaction. So just because you can get an erection and it may not be, you're not able to maintain it long enough, you're not able to get to orgasm quickly, things of that nature, those all count as erectile dysfunction. And it's pretty darn common, unfortunately. So about 25% or 1 in 5 guys at some point will have erectile dysfunction. The other important thing is for guys over the age of 50, about 60% of men over 50, so about 50% of men over 40 have some aspect of erectile dysfunction. So it's a more common than most guys think. And so the way that erectile function works, you've got these essentially these erectile tissue or these this tissue that has a bunch of blood vessels in them. As you get when you have stimulation, that muscle around those blood vessels relaxes, allowing the blood vessels to expand. You get an erection that compresses these veins that are around the blood vessels. So long story short, arteries expand, veins compress, you get an erection, and then you get these hormone essentially messages to cause the arteries to contract to get rid of the erection. So causes of erectile dysfunction. Main things I always tell guys is vascular things like blood pressure, cholesterol, things that are causing decreased blood flow to the penis are important in terms of causing erectile dysfunction, as well as diabetes, medications, post-prostate cancer treatments like surgeries versus radiation. Those are all pretty big risk factors for erectile dysfunction. So first and foremost, what I oftentimes will tell guys is if you have erectile function issues, that's erectile dysfunction is it's not necessarily a diagnosis or cause, but it's an effect of something else that's going on. So first and foremost, make sure that you're seeing a primary care physician to see if there's something that's going on with you that you don't know about, like blood pressure, cholesterol, diabetes, that could be causing the erectile dysfunction, because treating that can oftentimes improve the erectile function. So kind of going into a little bit more detail about those risk factors, a lot of people in the United States have diabetes, and usually guys that have diabetes have more severe erectile dysfunction, and they have issues with getting improvement for the erectile dysfunction from the treatment options like the medications, et cetera. And the reason is because diabetes not only hits the blood vessels themselves, they also hit the nerves that give guys erectile function, that stimulate the erectile function, the blood flow that goes to the penis. So the important thing with this slide is guys that have erectile dysfunction also have issues with erectile function, oftentimes that are more severe and have less potential effect from the medications. And so kind of like I just mentioned, I jumped the gun a little bit. The reason is because it not only hits those nerves, but also the arteries that affect or cause erectile dysfunction. And so the big things with diabetes is, along with diabetes, the risk factors for erectile dysfunction increase with guys that are older, guys that have less diabetic control, so guys whose A1Cs, the sugars are higher, along with if you have concomitant issues like blood pressure issues, cholesterol issues, having heart disease or being on diuretics, all of that on top of diabetes causes usually more severe function. Going into heart disease, Usually when somebody has heart disease, one of the most common first symptoms is actually erectile dysfunction. And the reason that happens is because the arteries that control erectile dysfunction are quite a bit smaller, or at least the arteries that go to the penis that give you blood flow for an erection are quite a bit smaller than other arteries in the body. So those arteries are the ones that have the most effect because they're smaller. And so before you have symptoms like heart disease, you can oftentimes have erectile dysfunction. I have a lot of guys that come into my office that have erectile dysfunction that potentially haven't seen a primary care physician or seen a doctor in a while, and chalked up the courage to come get their erectile function treated. And oftentimes because we're missing something or because they're having some other issue. But more importantly, erectile dysfunction can be a risk factor, a precursor to those other things. So one of the first things I always tell those guys is, no problem with treating the erectile dysfunction, but let's get you into somebody that can potentially look into, if you have something like heart disease, et cetera, to make sure that we're not missing a potential risk factor that we can treat pretty easily and effectively by a primary care physician. And so, something I always tell guys right off the bat is, we can treat your erectile dysfunction, but you at home, just in and of itself, improving your diet, low fat, low sugar diets, exercising at least 3 times a week with some kind of activity that's increasing your heart rate for about 30 minutes a day, stopping smoking, reducing stress, that's, easier said than done, and losing weight. All these things can not only make you a more healthy human being in general and decrease the risk of things like heart disease and diabetes, but more importantly, well, in my opinion, more importantly, that's not true at all, but also can decrease the risk of erectile dysfunction. So then low testosterone, this is a little bit of a sidebar, but basically low testosterone and erectile dysfunction kind of go hand in hand. So oftentimes with guys that have have erectile dysfunction, I'll check a testosterone to make sure that that's not also potentially potentiating or causing erectile dysfunction as well. Low testosterone is more common in men that are, well, older, along with guys that are obese, that have diabetes and have other potentially vascular issues, as well as have prostate issues. So about 40% of men over the age of 45 have low testosterone. So it's important to note that there's a chance that if you have erectile dysfunction, testosterone can be a potential factor. There's different ways to treat low testosterone, kind of like we say right here, injections, pills, gels, etc. But the important thing with the low testosterone is, with erectile dysfunction is if you have it, potentially low testosterone can be something you can get treated along with treating your erectile dysfunction. So prostate cancer. The surgery for prostate cancer cuts through the prostate, like you can see in the slide here, and the nerves that control erectile function run right past the prostate on the backside of the prostate. So with treating the prostate cancer, sometimes those nerves can take a bit of a hit. It's very common, about 50% of the time, guys, men's erectile function will take a hit after the prostate surgery. And in about 50% of those men, it takes enough to where you need some kind of therapy afterwards to allow you to continue to have erectile function. So there's a high risk of having erectile dysfunction and a potential for needing things that are a little bit more invasive, which we'll talk about in just a second. The other thing with radiation therapy to the prostate, that also affects the nerves around the prostate you see here. So that can also cause erectile dysfunction in patients. So you can kind of see here the wide range. I usually tell guys there's about a 50% chance that you're going to have some aspect of erectile dysfunction after any kind of prostate procedure, whether it's radiation versus radiation versus prostatectomy for prostate cancer. So the last thing here is Peyronie's disease. So Peyronie's disease and prostate cancer, erectile dysfunction also kind of go hand in hand. I apologize. It's kind of as a sidebar, but it's an important sidebar. Peyronie's disease is curvature that's caused from some kind of usually micro trauma that causes scar tissue or a plaque that forms in the penis. Peyronie's disease can also potentially cause erectile dysfunction because you have that curvature that then doesn't allow the penis to expand as well as it used to give you that erection that you're used to having. But also, erectile dysfunction can cause Peyronie's disease because when you have a decreased or a less rigid erection, when you're attempting to have intercourse, that can cause bending of the penis, that can cause that scar tissue to form. So Peyronie's disease and erectile dysfunction kind of go hand in hand. So if you do have some curvature, there's treatment options like injections into that plaque that can help straighten the penis out, but also potentially surgeries like a stitch that can straighten the penis out. Or if you have both erectile dysfunction and Peyronie's disease, we can do something called a penile implant, which we'll talk about here in just a minute, to straighten the penis out along with giving you erectile function. So treatment options. You see a lot of advertisements, radio ads, et cetera, about things like stem cell therapy, platelet-rich plasma, shockwave therapy. I'm actually giving a talk here this weekend at this national conference about these things in particular. The big thing with the AUA that our governing body says is these are investigational. Now, the important thing with this is certain ones work a little bit better than others, and there's more studies on things like shockwave therapy than there are on stem cells or platelet-rich plasma. I'll usually tell my patients shockwave therapy, long story short, has a bit more data on it, but there's certain patients that it's more effective, it can be more effective for than others. Usually that's patients that have erectile dysfunction that have some improvement with medication. So long story short, this slide is basically in here to say, there's certain patient populations that do better with shockwave than others. Stem cells and platelet-rich plasma are a little bit more experimental. You're going to be paying a lot of money for most of these things. I usually recommend staying away from stem cells or platelet-rich plasma unless you have a lot of money that's waiting to burn a hole in your wallet and you're interested in potentially some investigational therapies that probably won't do you any harm, but are unlikely to do you any good. The things that we usually recommend go on a spectrum of less invasive to more invasive. So medications, vacuum erection devices, suppositories, injections, and implants. And I know I went a little bit out of order and I'll go into detail and specifically. So medications, it's the stuff that you probably have heard of, Cialis, Viagra, things of that nature. Basically, they relax the smooth muscle better in the penis to increase blood flow to the penis. Usually work, depending on who you are and your risk factors, et cetera, about 75% of the time. Main side effects usually are headaches, some acid reflux, maybe a little bit of facial flushing, things of that nature. And most of the time, they play pretty well in the sandbox. So the medications, other than with nitrate medications, so a certain specific type of blood pressure medication, they do pretty well. The biggest thing with it is, it can work pretty well, but as time goes on, usually it doesn't work as well. There are certain patients that take them their entire life and have no problems, but the most common side effect oftentimes is that headache, and that can be pretty annoying for sure for a lot of guys. So there's a lot of guys where they have a great effect from it and take it forever and have no problems. But after a certain point, there's a certain percentage of patients that have issues or it's not as effective. And so something to note with the medications. So this is jumping ahead a little bit, but intracavernous injection therapy, basically it's an injection of a liquid version, if you will, of what's called a vasodilator, a medication that increases the blood flow to the penis directly, and you're injecting that medication literally into the side of the penis. Works pretty darn well, actually. So, it works usually about, the data shows 80 to 90% of the time in terms of finding a dose that allows you to get an erection that's rigid enough for penetration. It can vary in terms of how long a guy decides to continue to use this, meaning usually it's not that it's not effective, but usually it's just the guy gets tired of doing injections to the side of the penis every time they want to have an erection. However, I have plenty of men that use the injections and have done that for years, 20, 30 years even, that are very happy with the results and have no problem with it at all. The needle is pretty thin, and so it's usually just a little pinprick, if that. And the main side effects, for the most part, are a bit of discomfort, maybe a bit of swelling and bruising, and occasionally having some potentially a little bit of scar tissue if you've been doing it for a long time in a certain spot. Again, for the most part, it's not really failure. It can be failure of efficacy of it working well, but a combination of either it doesn't work as well or it gets annoying to use. The vacuum erection device is basically a glorified penis pump. It brings in, so you basically put in a suction over the device, like you can see in the picture. You turn on this vacuum suction, brings in blood flow to the penis. Usually I have guys use it in congruence or along with the medication like Viagra, Cialis, to get a little bit more rigidity or maintenance of the erection. It can be somewhat effective, usually with some kind of medication, like we said. I'd say the numbers here are a little bit elevated in terms of what we really see in real life. I'd say the effectiveness is usually around 50 to 60% in terms of being able to get a rigid erection. But the main thing is the side effects. It's a bit cumbersome. It's not the most comfortable thing in the world. And oftentimes it can cause some discomfort, bruising, along with some sensation issues, so decreased sensation in the penis. And so it's definitely something that we can use as a tool to try and improve the erection along with medications. But it's a bit uncomfortable, I guess, if you will. So suppositories, to be totally honest, I usually skip right past this. And the reason is because it's not as effective. It's not as effective as the other stuff, especially the injections. And it's usually a little bit more uncomfortable. So basically you're taking a little pill, you're shoving this pill in with an applicator, and it gets absorbed in the urethral mucosa to get an erection. The problem is it's not super effective. You can see here about 50% of the time does it work, but also it's uncomfortable. It can cause some bleeding, can cause some burning about 15 to 20% of the time. And so I usually tell guys, if you're going to do something that's going to be a little bit uncomfortable, the injections are more effective, and they're not as, to be totally honest, uncomfortable as these are. The only time I usually prescribe these is if the guy is not interested in surgery and is deathly afraid of needles, but the medication, the other stuff isn't working for him. Okay, so penile implant. So this is a surgery that usually I do if a guy has either failed other, essentially failed other therapies and is interested in having something that's going to permanently give them effective rigid erection. So kind of going into it, how it works, you can kind of see in this picture here, and I'll give you a little video here in a second, but basically it's cylinders that go into the penis itself, a pump that goes into the scrotum, and then a little reservoir that goes behind the bladder. You can see there. So essentially the idea is you pump this pump to get a nice rigid erection into those cylinders that are in the penis, and that fluid comes from that reservoir that's behind the bladder to go back and forth. And then once you're done with the erection that you've pumped yourself up with, you hold this button for about 3 seconds that's on the pump that gets rid of the erection. About 95 to 99% effective, meaning once you have the surgery and you're healed up from it, it works pretty much anytime that you want it to, and most patients are pretty darn happy with it. So 98% of patients are happy with the surgery. 95% of the patients' wives are happy with the surgery in terms of the effectiveness. And so basically how it works, I'll get into the side effects in a second. I'll skip past this because the main thing I usually use is that 3-piece device at the end. Oh, sorry. So the biggest risk factor real quick is infection. So anytime you're putting a foreign body into the penis, into the body in general, the biggest risk factor is going to be infection with it. The nice thing with this implant that decreases the risk of infection is this antibiotic coating, essentially, that comes with it. It decreases the risk of infection pretty significantly. Also, the risk of infection increases with guys that are diabetic whose A1Cs are above 8.5 or higher. So I always screen my patients to make sure that your A1C level is ideally 8 or under to decrease the risk of infection. The great thing is the implant, it's nice and natural looking. So it looks and feels like a natural erection because the cylinders take the entire course of the penis and it's custom fits to fit your penis. The pump is nice and hidden in the scrotum, so unless you're feeling around for it, you can't tell it's there. And the most important thing is sensation is the exact same. So it feels the same in terms of penile sensation when you're having intercourse. Orgasm feels the same as well. It's not going to make sensation or orgasm better than it was before, meaning if you had erections before and you were having issues with orgasm, it won't make the orgasms better, other than the fact that it gets you nice and rigid, and usually having a rigid erection makes it easier to get to orgasm. But sensation overall stays the exact same, which is great. So this is a little video that I'm going to skip past the beginning part and we'll get to the details here. So you can see this is normal looking penis. You've got that pump that's down in the scrotum. As you pump, the fluid comes in from that reservoir behind the bladder and goes into the cylinders. You get a nice rigid erection. And as you can see there, the cylinders go all the way to the end of the penis. Erection, you keep it as rigid as long as you want to. You can use it as long as you want to, whether that's 10 minutes or 10 hours. And then once you're done, you press that button on top of that pump. It deflates the penis by taking the fluid and going and taking it back up into the reservoir. So there it goes. So basically, I usually tell guys what to expect. It's a surgery that you're having done in, well, basically in the operating room. And so you're under anesthesia, little incision that I usually do in the scrotum. And it takes me about an hour and a half to do the procedure. You go home usually either the day after or the same day. You have a catheter and a drain that I put in afterwards that I take out the next day. You take it easy for about 4 weeks afterwards, and then you have a little teaching visit with us where we show you how to use the device, make sure you feel comfortable, and you start using it after that. A little bit of discomfort afterwards for about usually 2 or 3 weeks, give or take. For the most part, most guys are pretty much back to their normal physical activity about 3 or 4 weeks afterwards. Insurance. So overall, the big thing with this is insurance usually covers it, even Medicare, which is great. So for the most part, insurance isn't a problem, or oftentimes we can work with you to figure out how we can get things covered. So you'll see Cliff, you'll talk to Cliff and see his experience here in just a second. But the big benefits with the implant, I think, in my opinion, are kind of right on this page. They work. After the healing process, they work quite well, and they work pretty much 100% of the time. Usually it's covered by insurance. It's going to stick around forever. Usually on average, it stays around for about 15 years. So usually I tell guys it's going to last pretty much your entire sexual life capacity, essentially. And they look and feel about as natural as it gets. And so, again, the biggest risk that I always tell guys is infection. There are other small risks, things like a little bit of discomfort, like we talked about, bruising, swelling in the area in the scrotum. Also, it could be the device can fail, meaning it can potentially not work after a certain amount of time, usually on average about 15 years or so. It could also potentially erode different things like chronic pain. What I'll tell you is I've done quite a few of these, and for the most part, most of these are slim to none in terms of the potential risk factors. Really, the main one is infection. Knock on wood, I haven't had infection yet in any of the implants that I've done so far. So, um, so yeah, so erectile function, in a nutshell, the biggest thing I'll tell you, it's pretty darn common. There's definitely treatment options that we can give you. And the biggest thing is if you have erectile dysfunction, it's super important to make sure that you're talking to your primary care physician, having a conversation with your doctor as well as your partner about A, next steps, B, making sure there's nothing else that you can potentially do or get treated for in terms of heart disease, blood pressure, cholesterol, diabetes, etc. But more importantly, there's options for you, and there's ways that we can absolutely get this treated to where you can potentially be about as happy as you can get. So I'm gonna go ahead and turn it over to Cliff. And real quick, there's a question about injections and not being maxed out. So you can absolutely increase the concentration or the amount of or the dosage of the injections to get to a point where ideally you can find an amount that works for you. So you can definitely increase the dosage or the concentration of those injections to answer that question. Well, perfect. So I will stop talking and turn it over to Cliff.
Yes, good evening, everyone. What you're going to hear is the story, the trip that I took with my wife from the time I had ED to the time we conquered it. And basically, the story goes like this. When I was 58 years old, I was diagnosed with prostate cancer. My prostate cancer, when they did the, excuse me, when they did the biopsy, only one little portion of the prostate is cancerous, but being the kind of person I am, I said, I don't want it left in me so it could spread, take out the prostate. They took out the prostate, and needless to say, I was one of the people that ended up with ED. I did go back to my doctor, my regular doctor, my general GP, and I told them about it, and they put me on Viagra. I was one of the people that got terrible, terrible headaches from Viagra. And so they switched me to Cialis, then they switched me to Levitra and all these other ones. And the reality was none of them worked for me very well. So I went then back to my primary care physician and asked him, what's next? And he told me, he said, the vacuum device, the external vacuum device. And he was right. It does work. It works well. The only problem is it's not very spontaneous. It seems the more excited you are, the longer it takes to get the thing to work. And the biggest problem for me was the fact that you have to put a restriction band on the base of the penis to keep the blood in, to keep the erection. The reality is your penis turns a little cold, it turns blue usually, and it's not very appealing, to say the least. I will give you one warning about these erection devices. You don't want to get one from like Adam and Eve or any of these sex stores that you get for $25. You want to get a device that comes with a prescription from your physician to a medical supply store where you get a vacuum device that costs anywhere from $150 on up, but those are the ones that work. And these other ones, you're just throwing your money away. So after I had the vacuum device, I used that for about, I would say 6 months. And then I stopped using it and went into a major depression because I had no idea of what else was available to take care of the ED. Luckily, I got a letter of invite from a urology department that said, we're talking about how to cure ED. And my wife and I went and we listened to the physician. And needless to say, we learned about the other issues, the little pellets, the injections, and the implants. The pellets were not interesting to me at all. The injections were less interesting to me, but the implant sounded like it was something that could work and would be with me for a long time and would give me the kind of erections that I really wanted. What I did was the day after my 60th birthday, I had the implant done. Two things. Number one, ED is not just a male issue, it's a couple's issue. And when you go to the doctor to talk about implants or any of these treatment options, it's good to take your partner with you because a lot of times the partner does not understand what's going on. You as a man do. You think you've lost your manhood. That's really what it boils down to. And a lot of times women seem to be a little jealous and they'll come up with things like people have told me, oh, he's having an affair with somebody. I don't find him, he doesn't find me attractive anymore and all this. And that's the farthest from the truth. So my take is when you go to speak to the urologist, the prosthetic urologist, take your partner with you. So they are part of the, excuse me, they are part of the recovery from ED. I did have the surgery. For 2 weeks, I was in the house. I really didn't have lots of pain. Advils kind of took the edge off everything. I went back to work after 2 weeks. The third week, I went back to the doctor and they showed me how to use the device. I used the device. I will be straight with you. In the beginning, it did hurt a little because you're pressing on your scrotal skin. But usually after about the fourth or fifth time, you find the spot called the sweet spot, and it really doesn't hurt. You just feel a little pressure on your scrotum, and that's it. After the fifth week, I felt very good about things, and we started having relations again. And what's interesting is, even though we were having a little sex without the erections and stuff, we lost so much intimacy without being able to have penetration. It was amazing. I mean, here I am, 60 years old, and I'm feeling like I'm 18 again. And my wife's looking at me and saying, I don't want an 18-year-old again. I want just somebody that's 60 and can take care of me. So the device was implanted. It worked like a champ. You get a rigid, solid erection, good for any type of intercourse you want to have. After 6 weeks, like I said, we started having relations again. I went back to work. I went back to working out at the gym, the guys I used to work out with, and they had a shower with them. They had absolutely no idea there's anything inside of me. The thing that's nice about it is, number one, if you use the injections, you got to make sure you carry stuff in a cold bag and you have to refrigerate it, things like that. Or if you use the erection device, you have to, if you put it in your carry-on, I guarantee you somebody's going to say, what is that? And pull it out and start showing it to everybody. It's not very nice. You want to find the hole and creep into it. But with the implant, it's with you. Nobody knows you have it. You go through the airport, nothing goes off. It's totally blind to everything. People do ask me a few things like, what about the fact that is your orgasm the same as before? Well, the orgasm is the same as before, except of course it's a dry orgasm. There's no ejaculate because there is no prostate. And that doesn't seem to be a problem. I had the implant first done when I was 60. When I was 74, it finally gave way. And at 74, I had it replaced. I'm 77. If this lasts another 14 years and I'm still around, I will have that one replaced. It's as simple as that. All I can say is it is probably the best thing you can do to make sure you have erections for the rest of your life. And like the doc said, what's really neat about it is you can keep it up for 4 minutes, 4 hours, 40 days, doesn't matter. It's not going to hurt you. And you may find that your partner really likes that. So with that, I will turn it back to the doc and see if there's any questions.
Well, perfect. Cliff, as usual, thank you so much. Any questions from anybody now? And also, we'll send this out, I think, afterwards, where you can, view it again on your own. And also we'll send out a little message in terms of how to get a hold of us if you wanted to get in contact or make an appointment or something of that nature to talk about erectile dysfunction and talk about any of the options in general. But that being said, any questions at this point? And if not, I know we have no problem with ending it a bit early, but yeah, any questions that have come up, or potentially we can answer some, just some that we have prepared.